Dr. Perez, I would like to start by asking you, what are the differences between adults, children, and adolescents when they experience pain in general or orofacial pain in particular?
Well, that's a great question because I feel like a lot of practitioners sort of stay away from treating children with TM disorders just because of this particular difference. So children perceive pain a little differently than adults do. And so what may be a temporomandibular disorder in a young child can be explained as a bellyache. So parents learn to see this very clearly at the beginning, but a lot of practitioners don't. So that's one of the important things, is how they perceive pain. The second thing is how they relate pain. So children have a hard time explaining when they feel pain and how they express when they're feeling pain. So for example, a child who has pain in their masseter muscles, so the chewing muscles, they can wake up in the morning and say that they don't want to have breakfast, and they wouldn't give you more explanation that I just don't want to have that. And it could be because they have pain in their masticatory muscles. So that's another important thing to be able to understand and ask when a child is in pain from the masticatory musculature. And finally, a lot of parents can tell you this, but maybe practitioners cannot. Sometimes there isn't really pain, but that children are looking for secondary gain. So it's something to be aware of and to understand when a child is expressing pain. There might be something that they're looking to gain, and it could be something as simple as just attention.
Mm-hmm. So in your clinical practice, Dr. Perez, what are the orofacial pain conditions that you manage in pediatric patients?
Well, we created an adolescent TMD clinic in the Orofacial pain clinic. And as you know, we have one clinic a week, and it's been going on for about 5 years. We saw that this was a necessity when we looked back and did a chart review and realized that there were a lot of adolescents coming into our clinic. So we decided that because I had both specializations, pediatric dentistry and orofacial pain, that we could create a clinic just in this area, and we would have plenty of patients. So we do have plenty of patients. Now, to answer your question, we treat a lot of conditions, a large array of conditions, but as you know, we don't have a lot of little tiny kids. We see a lot of adolescents. That's why the clinic is more an adolescent clinic than a child and adolescent clinic. I think in the last 5 years that we've been treating patients, we probably have a handful of kids that are less than 10 years of age. And those kids have very particular conditions that are not the common everyday thing that we see in our adolescents. Whereas the rest of our patients are constituted for the most part in kids that are from 13 to 18 years of age. And the conditions that we treat there are an array of things. So from muscle pain conditions, temporomandibular joint conditions, we have children that have degenerative conditions of the jaw joint, as well as just pain from tooth wear.
And how prevalent are temporomandibular disorders in pediatric patients? Is it more or less frequent than in adults?
That's also a great question. So temporomandibular disorders vary widely. So if you guys were to look at the literature, you'd see some studies say 3%, and then other studies are going to say 70%. So that is a wide variation, which really leads us to believe that there's not a very good way of assessing TM disorders in the pediatric population. As you know, DCTMD is a great criteria to use in adults, but in children, although it's been created for children, it really hasn't been validated or used enough for us to be able to see studies that are using it consistently. So for right now, the prevalence is very wide and very varied, but at the same time, it tells us that it does exist. So children and adolescents do have temporomandibular disorders, and it seems that it's less frequent than adults, but it does increase as age progresses. So again, we do see it in children. The criteria needs to be a little more cleaned up, but we do see it in children for sure.
Mm-hmm. And are there any differences in prevalence between boys and girls?
Well, our clinic, interestingly enough, we're looking at the kids that we've seen since we started this adolescent clinic in the Orofacial Pain Center at UK, and it seems like clearly there is not a difference when we have children that are that have not gone through puberty yet, but then after puberty, definitely there seems to be more of girls than boys present in our clinic and in the literature as well.
Mm-hmm. And how do you recommend to diagnose TMD in pediatric patients?
So we tried to use different ways of diagnosing this in our population. We recommend that everyone starts with a good questionnaire. So we want to make sure that when we see a pediatric patient, we ask them certain questions, like, for example, is there difficulty opening your mouth? Do you hear joint noises in your jaw joint? Do you have pain in or around your ears or cheeks? Do you have pain when chewing, talking, or using your jaws? Do you have pain when opening your mouth wide or when yawning? Has your bite felt uncomfortable? Does your jaw ever lock or go out of place? Have you ever had an injury to your jaw, to your neck, or to your head? And then we also want to ask about if there's been previous treatment for temporomandibular disorders. So this is a really quick screening tool that we can use in our patients. Now, our patients already come with the complaint of an orofacial pain condition or pain, so we already start out with that. But a good screening tool to use in all your patients would be the questions that I just asked. When we see our patients in the orofacial pain clinic, we do have a questionnaire that's related to the pain and how prevalent it is, how intense, and how they would describe it, if it's associated to any other activities, for example, chewing. And then we ask a little bit about clicking and popping of the jaw joints and information on that as well. Once we have our questionnaire filled out, then we go and do a very thorough exam. So the examination is very important, as you guys know, because that'll give us the source of the pain, which is what we're looking for. So we start out, like I said, with a questionnaire, trying to understand where the pain is coming from. There is a good, important thing to talk about there is that, is the child filling out the questionnaire form or is the parent? So, we have to be careful because sometimes the parent really doesn't know when it hurts. And so we have to try to do an interview with that form in hand to make sure that we know exactly if the pain and all the characteristics of the pain and not just the mom's report. Once we have the child in the chair, then we, like I said, we do the exam, and we're very cautious of not really skipping any of the steps that we would do in an adult. So we want to make sure we palpate the masticatory musculature. We want to make sure we evaluate the joint correctly, not only for joint noises, but also for pain coming from the jaw joint. We look at range of motion. We make sure that there's no discrepancies there. We evaluate the tooth structures and hard tissues and make sure there's not a lot of wear, things that could give us an indication that there is overuse of the jaw joints. And that, gives us information about how to make a good diagnosis.
Mm-hmm. And how do the young individuals, the young patients, report pain? Is it easy for them to report, yes, this is hurting, or what are the cues that you can use to know if your patient is in pain?
Well, that's a great question, because when we have little tiny ones, and I said that's not very prevalent, but sometimes even adolescents have a hard time expressing when something hurts. And what we usually recommend is first to try to look at their expressions. So not necessarily ask, does this hurt? A lot of kids will shy away from that and just say, yes, it hurts, before we even start, because they don't want it to hurt more, clearly. So what we do is we try to use, for example, protective eyewear that's transparent and not dark. So we can look at the way their eyes open when we palpate a muscle, for example. That is, a painful muscle. And we try also to talk in their terms. A lot of kids won't really respond to, does this hurt? But you can say, is this the pain you're here for? Is this a condition? Or is this what it feels like when it really, really hurts? So those are just cues that we can use.
And what are the etiological factors associated with TMD in pediatric patients?
So that is a long question, and we could go really deep into it. But let's talk a little bit in general. So the etiological factors associated to TMD, the big ones we consider, first of all, is trauma. So trauma is a big one because it's one of the ones that has been really proven. So we know that there's macro trauma, so car accidents, big things like that, that definitely can cause a logical pain or dysfunction in the temporomandibular disorder and temporomandibular joint and structures associated to it. But there's another one that's pretty important, and that's considered microtrauma. So when we talk about microtrauma, we are talking about parafunctional activity. So for example, clenching of the teeth, grinding, or known as bruxism, lip and teeth biting, nail biting, and even abnormal posture of the mandible can be considered a parafunctional habit. So those are the big ones. Trauma is one of the big ones, micro and macro trauma to start out with. After we talk about trauma, then we definitely have to consider occlusion. Now, this was a big one. It's always been a big one because we always thought that if we fix the occlusion, we would take care of the temporomandibular disorder. However, time has passed and it's really told us that it's more important what you do with your occlusion than the occlusion itself. So if we can have a perfectly class 1 occlusion, but if we grind on it day and night, then obviously we may have more of a risk of having TM disorders than a patient that does nothing wrong that does not overuse their occlusion, and their occlusion may be not a class 1 occlusion. So we, at the end, after a lot of studying and things, we've noticed that occlusion really isn't a big factor for TM disorders. There are some that can be considered risk factors. So we have, for example, if young patients have skeletal open bites, overjets greater than 7 millimeters, class 3 malocclusions, or unilateral posterior cross bites, are occlusal conditions that can be considered of a higher risk of eventually developing TM disorders, but not necessarily just a causative factor straight out. And like I said, functional occlusion is how you use the occlusion that you were given. And that is also an important thing to look at because if you have an occlusal interference, for example, that causes your jaw joint to shift into a certain position, that may be a condition that could be considered a risk factor for developing TMD. So you want to make sure that something like that is treated because it causes your jaw joint and your masticatory system to be in a bit of an unstable position. So aside from occlusion, we also have systemic and genetic factors to consider. So there are cases in which we have children that have connective tissue disease or joint hypermobility that are also definitely at more of a risk of developing TM disorders. Genetic factors have also been looked at, and there's a couple of genes that have been found through the OPERA study. Those that work in orofacial pain are familiar, and certain genes have been found to have a relationship with some orofacial pain conditions. The connective tissue diseases that I spoke of at the beginning, for example, rheumatoid arthritis or juvenile idiopathic arthritis, are conditions that are related to temporomandibular disorders. And finally, we can't forget the psychological aspect. So when we look at adults with TMD, there's always a portion that is dedicated to the psychological condition of the patient and how that relates to their pain. Well, in children, we can't forget that that's also something to look into. So when we assess a temporomandibular disorder, we also want to make sure that the psychological factors that the child is going through at that moment have also been looked at and evaluated.
And do you have in your clinical practice, Dr. Perez, any specific tools for the screening of these psychosocial factors in pediatric patients?
Yes, that's a great question. So we started looking at the fact that we had a whole array of questionnaires for adult populations, but we said if the patient is less than 18 years of age, we weren't giving them anything. So this maybe was a couple of years ago that we decided that we would, with the help of our psychologist, our clinical psychologist in the Orofacial Pain Clinic, determine which of these have been validated for children. And we have 3, if I'm not mistaken, the PSQI, and there's one for pain management and pain perception, and there's a third one that we use in the clinic. So I think that we're evaluating these patients much better than we were before, and it's making us a little better in evaluating all the aspects especially the psychological ones, in treating these kids.
And going back to another of the etiological factors that you had mentioned, the microtrauma, what about sleep bruxism? What should we tell the parents when they come to the dental office concerned because their kids are grinding their teeth at night?
Yes, bruxism is a big one, and any of the practitioners that are listening in, or even patients, know that this is a question that you will be asked if you work with any child at all. So bruxism is a strong, habitual, non-functional contact between occlusal surfaces. It can occur while awakened at sleep, and so I'm glad that you asked specifically about sleep bruxism, because daytime bruxism is just a very different entity and it has very different characteristics. So when we talk about sleep bruxism, which is what we need to talk about, it is very prevalent in children. Anybody who has children will tell you they grind their teeth at night, especially when they're little. And usually what I try to tell parents is that it's relatively normal for your child to grind their teeth at night. But we also have to be very aware that there are cases in which this bruxism can be very damaging. So we have to evaluate tooth grinding. So if your child is grinding their teeth at night, but their tooth wear is insignificant, then, we possibly can say it's going to go away in a certain amount of years and it'll be just fine. Where other kids grind their teeth down to nothing. So we have children that have wear on their teeth that we can see the pulp chambers. And so they're very sensitive. They don't want to have ice cream. They feel very sensitive to any foods. And so those cases have to be analyzed a little bit better. That would be a good case to take to your pediatric dentist and ask or evaluate about. So bruxism, like I said, can cause tooth wear. It can cause periodontal damage and articular or muscle damage as well. So we have to be careful with it, but for the most part, bruxism is relatively normal and part of the neuronal development of children, and we expect it to be present until about 8 or 9 years of age, which is when we say that the number of neurons is the number of neurons you will have, and the connections being made are relatively stable. So we don't see a lot of bruxism after 9, but up to 9 we see a lot of it. Bruxism can be damaging because the force that we exert over our teeth is very intense. It can be up to 4 times greater than what we can physically do voluntarily. So it's a lot of force. The positions in which we grind our teeth is not usually the most stable position, so we can damage our teeth and our joints and our muscles that way. So if bruxism is something that happens every now and then, and it doesn't seem to be causing any damage, and the child is less than 9 years of age, I would probably tell the parents that there's really nothing to worry too much about. But if the bruxism is very intense, if it's every single night and wakes everybody up in the house, and we see damage on the teeth, or the child wakes up with pain in their masseter muscles, or has any other signs or symptoms, then it's time to consult and to ask further into it.
And how do we manage a patient that has TMD, a children and adolescent that has TMD? How different it is from the management of adult individuals? So the management of adolescents, for the most part adolescents, because that's what we see more in our clinic, has to be multifactorial, just because this condition is multifactorial. So we usually treat the child not from just one aspect. We try to use all that we have, all our tools that we have to be able to treat our kids. But there are important things that we have to consider before even thinking about treating a child that we have diagnosed with TMD. So one of the first things that we have to consider is that our objective is to decrease pain and adverse loading to the jaw joints and the masticatory system. We have to aim to restore function, and we have to try for the kids to be able to resume the activities of daily living that perhaps they're not being able to do. So the initial premise is that we really should not do anything that is irreversible in children. So that's very important. All our treatment, especially the initial portion of them, should be reversible.
Secondarily, surgery is really not indicated as first-line treatment at all in any of the TMD cases and should be avoided as much as possible, just because a child and adolescents are still growing and we don't want to do anything that will change this pattern of growth. And lastly, it's important to indicate that children and adolescents that have signs of TMD, really a large portion of them do not require treatment. So we're looking at kids that have, for example, temporomandibular joint clicks and pops. The majority of these children do not need treatment. Only about 3% of the kids that come to our clinic with some type of pain condition require aggressive treatment. So that's the initial and the important part. Now, when we talk about treating adolescents that have TM disorders, we always like to start with some self-help suggestions. We have an array of different things that we can do, and we select the ones that we feel that our patients are not only more inclined to do, but things that can actually help their condition. We talk about using moist heat or cold to help, especially muscle pain conditions.